And thanks to the organizers for inviting me this morning. And today we're going to talk about POTS and autonomic disorders, but mostly going to focus on POTS. And the title of my talk is POTS and Why Is It Difficult? And what I want to do today is try to make it easier so it doesn't seem as challenging as it can be. I have nothing to disclose. Any medicines that we discuss are off-label. There's very few medications that are actually indicated for autonomic disorders. Little by little, there's a few coming. So I want to start with the problem with dysautonomia. Let's talk about that term. Dysautonomia is a wastebasket term, which means the autonomic nervous system is not working appropriately. It is not a diagnosis, and a lot of people use it as a diagnosis, and they'll come to me and say, I'm here because I have dysautonomia. Now, dysautonomia, basically, there's hypoactive dysautonomia and hyperactive dysautonomia, and we'll talk about that in a second. POTS is often called a dysautonomia, and Dr. Ron Schondorf, who's a wonderful man, neurologist up in Montreal, who wrote one of the first papers on POTS, we'll get to in a moment. He calls POTS an autonomia, and we'll go through that, but it's really the autonomic nervous system working appropriately rather than inappropriately. If you Google dysautonomia prognosis, and this is a couple of years ago that I looked at this, but I check it every once in a while. Basically, it's generally a poor long-term prognosis. Death can occur from pneumonia, respiratory failure, or cardiopulmonary arrest. This is not patients with POTS, okay? And this sold the farm. I came up with this, I just put that term. I had a patient about 2 months ago who came to me, 40-year-old woman, looked pretty healthy when she came in, and first thing she said before I can even start asking questions is she said, I was sent here because I have dysautonomia. I just want to let you know, I've sold my house, I quit my job, I told my children I'm going to be dead in a year, and I've made out my will. Now, I was already emotionally taken by that, but by the end of our conversation, she was a puddle of tears when I explained to her that she was not going to die from this, okay? And I think that's a very important concept to understand, that POTS is not a deadly disease. It's annoying, has a lot of components, but it's not hypoactive dysautonomia, which we'll talk about in a moment. The hypoactive dysautonomia is, autonomic failure is a term used, and it's kind of like, the analogy is heart failure. And when you tell patients they have heart failure, they think, well, their heart stopped, right? Autonomic failure has a spectrum, just like in our last talk, we talked about spectrums and a lot of things. Autonomic failure means the autonomic nervous system is not working appropriately, okay? And so patients with autonomic failure, one of the key components that we see in cardiology is neurogenic orthostatic hypotension, and we're not going to talk about that in detail today, but those are the patients where they stand up and their blood pressure falls significantly. In the patients who really have autonomic failure, one of the key concepts that you can look for, if your patient's blood pressure drops significantly, let's say it drops 20, 30, 40, 80 points, and the heart rate doesn't change very much, it's very likely that they have a neurogenic cause for their orthostatic hypotension. Patients who are dehydrated, they stand up, their blood pressure can drop the same amount, but their heart rate is going to increase significantly. And so that is technically not a neurogenic orthostatic hypotension, although the autonomic nervous system is involved in those patients as well. But one of the key I just want to leave you with is, if you're looking for NOH, which is the easy way of saying it because the other one's a mouthful, if the patient stands up and their heart rate doesn't change, it's very likely they get NOH. Things like multiple system atrophy, which used to be called Scheidegger syndrome, which y'all probably not too familiar with unless there's any neurologists in the group, but that's a severe neurologic disorder, and that disease has about a 2 to 5 year prognosis where the patients die from diagnosis. And so that's what they're talking about when they're dying from dysautonomia. Parkinson's disease, pure autonomic failure. Pure autonomic failure is also on the spectrum of those same MSA and Parkinson's disease. Patients with diabetic neuropathy have a lot of autonomic disorders, okay? And in fact, those are the patients that really were first studied and recognized many years ago. but that's an autonomic neuropathy, and they have peripheral neuropathy as well. But those patients, their prognosis is really based more on their overall cardiovascular status and other things. It's not, they also don't have a death sentence once they get diagnosed. So then, we talk about hyperactive dysautonomia. As I said, the prognosis in most of these patients, unless they have something else going on, they have a normal lifespan. We'll talk about POTS, and the reason I put a small o in there is because now people who are cool in autonomic disorders is called postural tachycardia syndrome. They leave out the orthostatic because that was redundant, but POTS. Vasovagal syncope is a hyperactive dysautonomia. Anxiety, this is an important one. We're going to talk about this one. I don't know if there's any psychologists, psychiatrists in the room, et cetera, but anxiety is a very important thing, and a lot of people have it. But POTS is not anxiety. Anxiety is not POTS. People whose heart is racing with the heart going at 180, 200 beats per minute, and they're dizzy all the time, they get anxious. So they can have a secondary anxiety related to their POTS, but it's very careful. We try to sort them out so we don't basically treat the wrong thing and also put the patient in the wrong direction. Inappropriate sinus tachycardia is a hyperactive dysautonomia, and then Takotsubo syndrome, and if you're not familiar with that, that's the broken heart syndrome. Those people have a huge outpouring of epinephrine, adrenaline, which causes the heart to basically stop at some point, it looks like an infarction. But interestingly, for all the cardiologists out there, in my experience, that if the patients survive, which they usually do, by 2 or 3 days, their heart function is back to normal. Even if their ejection fraction is 10% when they come in the hospital, it goes back to normal, and those patients do well. But that's a hyperactive dysautonomia. So this is the autonomic nervous system, and if everyone just memorizes this, it makes everything else very easy. We've all seen this along the way, but basically, it's very important to talk about things in groups. The fight or flight concept is the sympathetic nervous system. And I actually still refer back to this concept, even in my head when I'm seeing some patients at times, because if you think about the fight or flight system, then everything else becomes easy, okay? So, you know, they used to talk about the caveman getting chased by the, by the dinosaur. Never happened, okay? Now they talk about the patient being chased by a bear. But in any case where you have to get up and run, the heart rate has to increase. The blood pressure increases a bit. The pupils dilate so that you can see better. We don't urinate. We don't digest food, so digestion stops. So a lot of GI issues that you see out there are basically from patient having too much sympathetic activity. Patients, we don't urinate when we're running away from something, right? We sweat. So if you think about the fight or flight concept, everything else becomes simple, actually, and if you just sort of look at that. But basically, if you look down the line, the sympathetic system dilates the pupils, you don't salivate, relaxes bronchi, which can cause shortness of breath issues, all of these things. The sympathetic nervous system does not discriminate. And so basically, when that's going off, then all of these things are happening simultaneously. So if you have a patient who comes in and they say, I'm here because my heart races, and they have nothing else going on, it's very unlikely to be an autonomic disorder, an overactive sympathetic nervous system, because, and I question patients, up and down, and they fill out questionnaires before they see me, but if they get nothing else going on, it is probably not POTS, and it's probably not an autonomic nervous system disorder, because otherwise everything else would at least have some issues. People are going to have GI issues, they're going to have urinary issues, they're going to be sweating too much, tired, fatigued, anxious, nervous, jittery, right? Then on the parasympathetic side, the main, most famous player on the parasympathetic side is the vagus nerve, but we get a lot of other parasympathetic players that affect the eye and the urinating, et cetera. But the vagus nerve is really the one that's the most key in terms of causing symptoms. Interesting, and I find the vagus nerve fascinating, but we always kind of think of and taught in medical school and other healthcare professionals, et cetera, that the vagus nerve is either on or off. But the vagus nerve does multiple things at the same time, and so it's really, unlike the sympathetic nervous system, you can just have one thing going on with the overactive vagus nerve and everything else can be fine. So that one is a little bit more tricky. Even, the vagus nerve comes down the carotids, the one on the right side, one on the left side, they do different things. One innervates the SA node of the heart, the sinoatrial node. The other one does the atrioventricular node. And so they're doing different things. So this paper is back in 1993, and this is one. Ron Schondorf was a fellow at Mayo Clinic. Phil Lowe, who was a wonderful guy, was his mentor and attending at Mayo. And basically what they wanted to do, they noticed a lot of these patients they saw who had all of these symptoms. When they stood up, their heart rate seemed to be going too fast. So they really just went through the Mayo Clinic database, and I think Ron did most of the work. But Phil is often given credit for the disorder, but they worked on it together. And what they found is the common theme in these patients with all of these symptoms going on was when they were standing up, their heart rate went up. So POTS was kind of thrown around in the literature very, very, very abstractly. It wasn't a big diagnosis yet. And so what Ron and Phil are famous for is actually kind of coming up with that term and really popularizing it. And that's where we get POTS from this one paper. And if you look back to this paper, it's actually a very interesting historical perspective. So the key question is, why is POTS difficult? So before I get into this, I think a lot of folks who don't deal with these things just think, oh, the patient's autonomic nervous, for some reason their adrenaline is just going too high, the sympathetic nervous system is just out of control. But there's a really very good explanation for most of the patients in terms of physiology, which we're going to talk about. And I'm hoping that as I talk to you about this, that it will change your perspective on what POTS is, because POTS is not some random high adrenaline thing. POTS is a very well studied, and the physiology is very well known at this point now. It's taken a while, but at this point we know. So the problem is the symptoms can overlap with autonomic failure. So interestingly, even the patients whose autonomic system is not working, those patients and these patients get dizziness, they get short of breath, they can get chest pain. So the symptoms overlap, but generally when you look at the patient and you look at their comorbidities when they come in, you can kind of at least grossly separate them out into what you think is going to be either someone who's hyperactive autonomic system or a hypoactive autonomic system. But the symptoms are very commonly overlapping, and even interesting, the treatments for both disorders are very similar, but they're very different in terms of the prognosis, and they're really very different disorders. This stuff was not taught to us anywhere, not in medical school, not in residency, not in fellowship, not in nursing school, not in PA school, not anywhere. No one teaches this stuff, and still no one teaches this stuff. I talk to the residents whenever we have a residency up at Kennestone. They still don't get it taught. No one teaches this. I'm working with a group, I'm one of 7 faculty members, and we go every year now to Clearwater, and we have 40 residents from around the world come in, and we are teaching them, and we feel like one by one will make a difference, but they go back to their institutions, and actually as part of this program, they're required not only to come, listen to the talks, have a nice meal, and spend the week in Florida, but then they have to go back to their institution and give lectures regarding an autonomic topic to all of their colleagues. So it's kind of like trying to connect the dots and get people out there to teach more of this. The patients can be challenging. They have multiple systems, multiple organ systems are involved. A lot of these patients have medical PTSD, and for those of you who aren't familiar with this term, a lot of these patients go to their physicians and they are just told it's just anxiety, they're gaslit, some are yelled at. I've heard these stories that make me cringe, but patients get yelled at, they say, no, you got too much, it's complicated, or you're making it up. And so these patients, by the time they see me, the average patient who sees me probably has already seen 10 medical professionals before they see me. And so by that point, they're already skeptical. Recently, when they were going to close down TikTok, I never look at TikTok, but I thought, hey, before they close it down, I'm interested to see if any of my patients have ever mentioned me on TikTok. If you go on TikTok and look at my name, there's a patient with red hair who had the best. I couldn't ask for this. You couldn't pay for this kind of advertising because it's awesome. But this woman was sitting in her car before my visit, and she was doing a video of herself telling how nervous she was and scared, and oh, here I go again. And then she does another video afterwards, and she's ecstatic, and she's going through all stuff. And I'm thinking, like, you couldn't pay for marketing like this. It's so awesome. But like I said, I wouldn't even look at it if they weren't going to post on TikTok. So here we go. And again, this is not anxiety. It could be secondary to the disease, but it's not anxiety. So I want to talk in detail about a patient, because I think it's really important. If we go through how I evaluate a patient and you see what we do, then you can kind of get a framework for how do you evaluate. I want everyone here not to necessarily treat these patients. You can if you like, but I want you to recognize them because they're easy to recognize. I always think of the analogy of seeing the tree through the forest with these patients, because a lot of times these patients come into the office, and by the time they sit up on the table, when I walk in the room, I know what they got before I even ask them one question. But once you see it, you can't unsee it, but you have to know what you're looking for. So this patient came to me from Canada, actually. She was in Calgary, and she had relatives in Atlanta, so she came down to see me. This is actually about last August. She had a sudden onset of severe symptoms which occurred after COVID-19, and this is COVID-19. It's a big instigator of POTS that we see now, and COVID vaccine, and we can talk about that later. But she got the COVID in late May 2024, and her heart rate was going up as high as 192. So she went to the ER, and they told her she had SVT. Well, for any of the cardiologists in the room, for anyone else, when you look at an EKG, if someone's heart rate is sinus tachycardia at 192, it's impossible without doing an EP study or further testing to distinguish. They look the same. You can't see any P waves because there's no room for a P wave, right? So they told her she had SVT, and as it turned out on a Holter monitor, she eventually had a little minor SVT, but that wasn't an issue. So she went to the ER, and for this high heart rate, they started on antidepressants. What? Well, the antidepressant didn't work, made her symptoms worse. So they told her to go to the US for evaluation and treatment. She's from the US, and they won't see you in Canada unless unless it's an emergency. So they said, we're not going to see you anymore. So she came to see me, which was nice of her, and it was a lovely young lady. So here's her symptoms. Her cardiovascular symptoms. These are the standard heart symptoms that everyone has, right? But these patients have some nuances. So she had chest discomfort described as pressure, shortness of breath with exertion, and also air hunger. And for anyone who doesn't know what air hunger is, it's really important to kind of grasp this from a patient, whether they're getting out of breath when they're active, or if they're sitting around and they just can't take a deep breath, they feel like they can't get enough air. Those patients, if you hook them up to a pulse oximeter, have 99% oxygen saturation, but their brain is telling them they're not getting enough air. That's air hunger, and that's what a lot of these folks have. Palpitations, racing heart, worse when she was standing for a while. Lightheadedness almost every time she stood up. Syncope, episodes of fainting and near fainting, high-pitched ringing in her ears. They also get visual changes, tunnel vision. I'm impressed and amazed when I see thousands of patients that they almost all have the same description of what happens. It's really impressive. Most get tunnel vision, some see sparkly lights, many have muffled hearing, and a lot of them will have associated nausea and sweating, cold sweats, and clamminess. We're not going to talk about vasovagal syncope today, which is another one of my favorite topics, but it's really important to recognize when a patient talks about fainting. If they're just lightheaded and they pass out, that's not a vasovagal thing generally. If they get these other symptoms, queasiness, cold sweats, clammy, heart pounding, that's a vasovagal, and I just wanted to sort of throw that in just to think about, and we'll have another talk on that at some point, but really it's not that hard to distinguish patients who have non-cardiogenic syncope if you ask some good questions. She had a Holter monitor showing sinus tachycardia, some bradycardia, episodes of SVT, and an atrial run. As I see this, I actually didn't think about this, but I saw a patient yesterday who came to me from rural well, it's kind of rural Georgia, and 30-year-old woman. And when we started talking, and I asked her what's going on with her, she says, well, I have sick sinus syndrome, I got a pacemaker. I'm like, wait, stop. What? She goes, yeah, it's sick sinus syndrome. I said, what's sick sinus syndrome? Well, they said my heart was going too fast, I was going too slow, so they put a pacemaker in. By the time I finished evaluating her, the young lady had POTS and vasovagal syncope, and as we'll see later, the POTS actually triggers the vasovagal syncope, so the slow heart rate was not a sinus bradycardia, it was a vagus nerve firing, and actually may not have needed the pacemaker, but I kind of try to encourage her. That's a good thing she got it anyway. It's there, and blah 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 blah. And I didn't want to make her feel bad, but pacemaker, that's not sick sinus syndrome. So the non-cardiac symptoms, and this is, I think, where as a cardiologist you're going to get, held up, and that's why a lot of people don't want to see these patients, because they have a lot of non-cardiac symptoms, and a lot of times that's the key to the whole diagnosis. Almost all of them have fatigue. That's, I put the most important ones in red, but it's rare when someone comes to me with POTS and no fatigue, but most of them have fatigue. They also get a lot of brain fog, which is another very prominent symptom. GI, nausea. This girl had irregular bowel movements. She had frequent diarrhea and constipation, which most gastroenterologists would tell her is irritable bowel syndrome. But we'll talk a little bit more about GI stuff in a little bit, but probably not. I don't even know if irritable bowel syndrome by itself is a thing, as we talk about some of the other stuff coming up, but a lot of these patients will have GI issues. When they don't, I actually tell them you're lucky, because the ones with the GI issues, a lot of time it's the most prominent symptom they have, and they just happen to be seeing me because their heart's racing, but if I could get rid of their GI stuff, they would be much better off, and that's a big issue. It's also important, as we'll see later, because patients who have GI issues can't hydrate. If you can't orally hydrate, you're going to see that POTS gets worse. Neurologic, and this is a big clue. She had new lower extremity paresthesias. Before the COVID, she never had any numbness in her legs. She's 20 years old. Now she's got numbness and tingling in her legs, started after the COVID infection. She's had motion sickness, but that's been, for most of her life, so that's not new. Frequent headaches, migraines, memory issues, the brain fog, as I said. She felt internal shaking, anxiousness. Musculoskeletal-wise, and this is another key component, joint pain, not just one joint, but diffuse joint pain, frequent dislocations, subluxations. She was hyperflexible, bruised easily. She had a history of tendinitis in both knees, and she had all kinds of orthopedic issues. Her joints cracked. I asked them if your joints snap, crackle, and pop, and the majority of them will say, how do you know that? But they have a lot of snap, crackle, and popping in their joints. Flat feet, knock knees, scoliosis, hip dysplasia, and history of frequent dislocations. Dermatologically, has a history of rosacea, but she has frequent hives and flushing, and she also had recent hair loss. She has some urologic issues with interstitial cystitis, which is another biggie that goes along with POTS. And endocrine, she has a family history of Hashimoto's disease. So, if you were playing a mystery game, just from this slide alone, now, obviously, I've gotten to the point where I am now, where I understand all this stuff. But when I see this thing, all I have to see is this thing, and I could, without even seeing the patient, I could tell the patient not only their issue, their diagnosis, and I can predict everything else about them. And they look at me sometimes when I ask questions, and every question, 10 questions in a row, they're answering yes to, and has nothing to do with their dizziness. They start to get a little suspicious, like, are you reading my mind, et cetera. But all of this stuff becomes very, 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 very significant, but there's a pattern in these patients, and once you know what the issues are, then you can predict exactly what their symptoms are, which is kind of fun. So on physical exam is generally not that helpful in these patients, but there are some clues and there's some things to do. Obviously, you want to rule out they don't have a murmur, they don't have fluid in their lungs, et cetera, for their shortness of breath, so you want to do a regular physical exam. The vital signs are critical. And so this is a key concept. So when you do orthostatic vital signs, I recommend always do supine, sitting, and standing. A lot of these patients have symptoms just sitting. They don't always have patients just standing. And as we'll see, the physiology becomes important. So supine, blood pressure 108/75 with a heart rate of 85. Sitting, blood pressure doesn't change. Heart rate goes up to 118. She went up 33 beats per minute just to sit. You think she's going to have palpitations? Well, maybe. You can think she's going to have dizziness, not because of the blood pressure, but she could have dizziness just from this. And then she stands up, her heart rate goes to 133, blood pressure goes up a tiny bit more. Those orthostatic vital signs are one of the key things you can do in the office to distinguish what's going on for the patient. Physical examination, she had a high arched palate. And if you've never seen one of these things, I'm not probably the only cardiologist that looks in the mouth of every patient that comes in my office now. So I've seen more palates over the last 10 years than anyone could ever believe. And some of these high arched palates, when you look at the roof of the mouth, sometimes it's like a less than a centimeter gap from the sides of the palate. It's unbelievable. Normally a palate should go, it should be rounded and go from one tooth line to the opposite tooth line. If you see something that looks funky, that patient has an issue, and that's not normal. Lungs were clear, heart was fine, abdomen, absent bowel sounds. A lot of these patients have quiet bowel sounds. As I said earlier, if your adrenaline is high, the gut stops. Peristalsis stops. These patients get gastroparesis because their stomach's not emptying. They get constipation. They get lots of GI issues, okay? But the high adrenaline alone can do that. And you can actually hear that. I listen to everyone's belly very carefully on physical exam now. Neurologically, was grossly normal. Musculoskeletal, and this is important. She had lots of hypermobility and a Baton score of 9, and I'm going to give you a little picture on the next slide of what a Baton score is. But the Baton scale, Dr. Baton was interested in connective tissue disorders, and so they came up with these joints that they test to see if a patient may have a connective tissue disorder. So basically, we'll get into that more in just a minute, but hers, out of 9 points, she had a score of 9. Dermatologically, she has stretch marks, stretch marks. This is a thin young lady, and if a patient comes in and tells you who's otherwise thin and not having weight changes, they get stretch marks on their hips, thighs, breasts. That's not normal in a 20-year-old. She didn't have a baby, et cetera. I mean, it's really something to think about. And psychiatrically, she has a history of generalized anxiety, some depression, but now her anxiety's been worse and she's had all this stuff. So this is the Baton score, okay? And this is from the EDS, Ehlers-Danlos Society. Anyone interested in connective tissue disorders, this website is awesome. The Ehlers-Danlos Society website has all kinds of cool information, and like I said, I've become an expert in connective tissue disorders and doing this stuff, and you can find almost anything you want there. But basically, the key thing is, if the patient can bend their wrist and pull their thumb back to touch their forearm, you get a point for each side. If the pinky, you pull back on the pinky, if it goes past 90 degrees, you get a point for each one of those. The elbows go out. If the elbows hyperextend past 10 degrees, you get a point for each one of those. If the knees hyperextend past 10 degrees when they stand up, you get a point for each one of those. And if the patient can touch their hands to the floor, palms to the floor, not fingers. Fingers don't count. Palms to the floor, you get hypermobile hips. Some of these patients like to show off and they can put their head on the floor just by bending. It's unbelievable. And some of these patients, and when I say some, I should say most, they didn't even know they had it. When I ask them if they could do this thing with their wrist, I didn't know I could do that. The ones who don't know it, when they do it, actually you'll hear the wrist, it will pop. It makes a noise because they can do it, but they didn't know they could do it. Some of them play around with it and do their party tricks and stuff, they call it. So, I want to show you this testing. And I don't see Tony Bowdy out there, but Tony, yeah, there's Tony. Tony does these tests as well. And this is called originally it was called an ANSAR test, and I still call it an ANSAR test. In fact, in Wellstar, even if you need a tilt table, they'll call up and say, I need an ANSAR. Ironically, the company changed it to Physio PNS, so they changed the name, but we all still call it ANSAR, and it makes sense. Autonomic nervous system testing. He uses the modified Ewing maneuver. So, as I said, this Dr. Ewing, back in the 70s, basically came up with a series of provocations to test autonomic dysfunction. And they're very simple. Basically, you put the patient at rest and see what's going on. Then you have patients do deep breathing. And this respiratory rate of 6 breaths per minute. So 1 breath every 10 seconds. 1 divided by 10 is 0.1. The frequency of the vagus nerve is 0.1 to 0.15. So when you breathe slowly, like you do in meditation, etc., you engage your vagus nerve. And so what this test does, it really accentuates that, and we can see how doing that changes their autonomic activity. The other thing you do is a short series of Valsalva maneuvers, and there's a lot we could talk about Valsalva. It's like a huge thing in autonomic disorders, but Valsalva is it's a big sympathetic challenge, believe it or not, even though a lot of us were taught to have the patient Valsalva from SVT. The final phase of a Valsalva causes a vagal output, so you can slow down the heart rate. But the beginning of it actually speeds everything up, and it's a very difficult, sympathetically challenging maneuver. And so this device calculates sympathetic and parasympathetic activity, as well as heart rate and blood pressure for each stage of the test. And just not to go into details, but basically, the way it works, it uses a combination of heart rate variability and respiratory rate. And if you know your heart rate variability and your respiratory rate, you can put these different categories, and you can figure out what's sympathetic activity and what's parasympathetic activity. I want to show this part first, which is just the graph of the patient's heart rate for this patient. So you can see the heart rate's all over the place. This is just a regular, just if you had an EKG, telemetry, or anything in the office. The patient's heart rate at rest is all over the place. Now, part A, they're just sitting down. As I said, part B, they're doing deep breathing and so forth. In part F is where they stand up. Now, I happen to be in the room for this, and it was very impressive because the heart rate's fluctuating, but kind of in the 90s. You can't even give one number, right? It's all over the place. But now this young lady stands up, and this is characteristic. You can see this heart rate keeps going up, up, up. It got up to 140. At this point, the young lady told me that she couldn't see anymore, and she was starting to get nauseated. So at that point, I told them, hey, let's sit her down. So normally we don't even keep the Ansar going, but I happen to be there, and so I said, hey, just don't shut it off. I want to see, what's still going on. And so here she sits down. Immediately on sitting, the heart rate comes down. That's POTS. If someone's heart rate goes up when they're standing and it plummets back to normal when they sit, that's POTS. I don't need anything else to tell me what POTS is. That's POTS. But so that goes up, comes down. That's her POTS. She did not pass out. Put her down. I always say that the patients who have vasovagal syncope, most of them are smart. If you have a patient who tells you they faint and lose consciousness 4, 5, 10 times a week, and they have vasovagal syncope, then the patient needs education, okay? Because patients know if they start to feel those symptoms, if they sit down, and especially if they lay down, put their feet up on a chair, or put their feet up against the wall, they're not going to lose consciousness. So very few people with frequent vasovagal fainting lose consciousness. It's vasovagal near syncope. Because once they've had it once or twice, they don't want to do that again. Now, the interesting thing here, and Tony will appreciate this, but basically, the red lines are sympathetic activity and the blue lines are parasympathetic activity. During the standing portion of the test, look at this big blue spike, which is her vagal activity. So it's nice to see it objectively. So when she was having a vasovagal response, her vagal activity went up. There's nothing else that's out there that can give you this sort of information and really tell you what your system is doing, and it's really pretty cool. This is just a whole report, and the one thing I want to point out in this, the red, again, sympathetic activity, the blue, parasympathetic activity, and this is during the entire test. I named this the coloring book sign a long time ago because it looks like some kid took a crayon, 2 different colors, and just was scribbling, right? When I see this, I can almost look at this alone and know the patient has POTS because their autonomic nervous system is so wacky, it's just overreacting to everything. I didn't put a normal in here, but normally at rest, both of them are kind of low and really sympathetic and parasympathetic activity. There's like a straight line here. In part B, when they're deep breathing, you get this big blue spike because that's your vagus nerve, because that's what runs our respiration. Part C, they rest, and it goes back to a straight line. Part D, you get a big red spike because that's their sympathetic activity. And then part E goes back to a little straight line, and then part F, you get one little red spike when they stand up, you're done. This does not happen in patients who are normal, okay? So it's just some good information, just a little visual to see how we look at this stuff. So for the criteria, the American Autonomic Society and then the American Neurology, back in 2011, they put this objective POTS criteria. I will make a disclaimer, I don't love the criteria, and I'm trying to revise it, and we're working on an international level to get condone the next meeting so that we can change the criteria a bit, but basically, sustained heart rate increase greater than or equal to 30 beats per minute. The key thing about this is sustained, okay, within 10 minutes of standing. So it's not that they stand up, their heart rate goes up greater than 30, and within a second or 10 seconds, it goes back to their baseline. That's not POTS. All of us, if we stand up, our heart rate goes up to compensate, and then it goes back to normal. Patients with POTS, it's sustained. Oftentimes, the standing heart rate is greater than 120. For adolescents, 12 to 19 years old, it has to be greater than or equal to 40 beats per minute. They changed this back in 2011. Now, here's the argument. I did a debate now 4 years ago, with the man at the time, who was still actually one of the heads of neurologists at Mayo in Rochester. And we had a debate about this stuff. And in our rebuttals, I said, at Mayo, what happens, if your heart rate goes up, they do a tilt table. If your heart rate goes up 25 beats per minute, they send you home. And they say you don't get POTS because it has to be over 30. In fairness to Mayo, if they saw every person individually that presents to Mayo looking for POTS, they don't have enough physicians. So they kind of use it as a screening tool to screen them out. I do the opposite. I want to see more because I want to help those folks. So I don't look at that 30 beats per minute. And actually the question I asked them, I said, what happens if the 19-year-old patient comes in, they get on a tilt table, and the heart rate goes up by 35, but their birthday's tomorrow, and they're 20. All of a sudden, the criteria changed, and now they had POTS tomorrow. They didn't have it today. So anyway, so I'm really trying to get rid of. I'm really trying to get rid of this heart rate thing, and kind of. I'm working on it in a few different ways. Absence of orthostatic hypotension. If someone's blood pressure drops, as I said, that's orthostatic hypotension. That's not POTS. However, if a patient with POTS gets dehydrated above and beyond their normal, they can show orthostatic hypotension and POTS, and a lot of times I can sort it out when I do a tilt table or the Ansar test. And basically, as I say, absence of orthostatic hypotension, and the orthostatic tachycardia may be associated with symptoms of cerebral hypoperfusion. Most of these patients, when they stand up, if they don't have symptoms, they don't have to have it all the time, but it's probably not POTS if they're not having symptoms on a tilt table, et cetera. And technically, the symptoms have to be greater than 3 months, although, as I said, a lot of these patients recently with COVID and COVID vaccine, they develop symptoms within 2 weeks after their COVID, and it just never goes away. I put this one up here also, and this is basically the Heart Rhythm Society, American Autonomic Society, American College of Cardiology, AHA, et cetera. They reconvened in 2015 and kind of did some another set of criteria. Again, not much changes, so it wasn't really a big change. So let's talk about the diagnosis for this patient. Number one, hypermobile Ehlers-Danlos syndrome. She has the joint pains, frequent dislocations, hyperflexibility, easy bruising, all kinds of orthopedic injuries. EDS, or EDS for short, is the most common thing I see in patients who have POTS. And if you just look for this, then all of a sudden, a lot of things become clear. As I said, when I walk in a room, if the patient's sitting on a table and their legs are crossed 3 times, I don't have to ask them questions. I can't do that. Most of us can't do that. When the patient comes in and they put their arm behind their head, but they're scratching the lower back, no, I can't do that. You can't do that. That's all right. So I would love to give a whole talk on EDS at some point because it's fascinating. But hypermobile Ehlers-Danlos syndrome is not the EDS we learned in medical school and other healthcare training. Most EDS, the classical EDS, which is what it's called, is a collagen disorder. The collagen molecules. The collagen bundles are abnormal. You can do genetic testing, and there's at least, I think there's up to 15 different collagen types. The collagen is going to be abnormal. Patients with hypermobile EDS, the collagen is normal. Interestingly, it's the matrix proteins, the glue that binds the bundles together, that's abnormal. And there's a group out of Charleston at MUSC who's a wonderful group who's identifying some of the markers, and hopefully within the next couple of years, we're going to have a genetic swab and testing for hypermobile EDS, but for now there is none. We do genetic testing to make sure that they don't have other more serious forms of EDS or other connective tissue disorders like Marfan syndrome, et cetera. But the other thing is, and this is just another aside, if the patients don't meet all the criteria for hypermobile EDS, but they still get this hypermobility, hyperflexibility, there's something called hypermobile spectrum disorder. So again, back to the spectrums, but it's really important because those patients probably have the same genetic abnormality, it's just not manifesting with the particular joints. But again, I just want to emphasize the EDS, I talk to the patients, this is the foundation for their problem. They're born with this. And again, it's like being a mind reader. I said, I'll bet your mother has this. And they look at me like, you know, my mother has the same stuff as me. It's very mother-daughter past. Boys get it, but it seems to be, and I'm not a geneticist, but it's really experientially, it's really about 50% of boys get if mom got it, almost 100% of women get if mom got it, and then, oh, grandma has, oh, you know, maybe that's why grandma was always fainting. We never knew, right? And she always, her hips would fall out, and it's, no, like you start asking the questions, and it's fascinating because the patients have these stories that all of a sudden make sense. So that the EDS is the foundation. She also had these new leg paresthesias, and this is a key concept that I discovered actually. I see so many patients that I get to make diagnoses and discoveries before the research places actually get to do research. So it's kind of fun. But every one of these patients who would come to me early on with post-COVID long haul, et cetera, they all have neuropathy, and I would send them for biopsies, and they would have small fiber neuropathy, which is something that you can't diagnose that with nerve conduction velocities, EMGs, because those are the big trunks, the long fibers. Small fibers are literally just little hairs that connect from the root of the nerve to the target organ. In this case, it's the veins. The veins are now denervated, so they can't constrict when the patient stands up, and we'll talk more about that. But the small fiber neuropathies are very important. Just a month ago, this big study came out saying, we've discovered that small fiber neuropathy is a key to post-COVID long haul syndrome. And there's a couple papers out there now. But like I say, I had the advantage of just seeing a lot of people and getting to kind of do this early on. So I feel lucky about that. The next thing, we're not going to talk about this, but this is a whole topic in of itself. Mast cell disorder. Mast cells, as you recall, are white blood cells. We all have them. They run around our body and they protect us and prevent us from infections, external toxins, etc. When mast cells contain about 100 or more different chemicals, including histamine, which is only one, but they get 100 others. They get all kinds of inflammatory mediators. They get bradykinins. They have interleukins. They get vasodilators. They have all kinds of chemicals that cause diarrhea, abdominal cramping, etc. Loads of these patients have mast cell disorder, and when the mast cells encounter in us, if you don't have mast cell disorder, the best example, I love learning by living. I was at a meeting in Italy, and one night I had some bad food. It tasted good until after dinner I had to run to the restroom because I suddenly had severe cramping and some GI issues, and it was food poisoning. And that's a great example of how a real mast cell reaction, what it's supposed to do. Once they encounter this bad stuff, they release their chemicals, and our body wants to get rid of whatever came in. So these patients with mast cell disorder, they react to air. I joke about it. They react to water. They actually really do react to water. They react to so many different foods and things. And as I said earlier, a lot of the patients who were told they have irritable bowel syndrome, if you treat the mast cell disorder, guess what? All of a sudden they don't have IBS anymore, because most of the mast cells in these patients live in the gut. You can actually biopsy for them. And these patients have loads of food intolerances. And one of the key ones is gluten. They don't have celiac, but they have gluten intolerance. They have lactose intolerance. And a lot of them have intolerances to things like tomatoes and other sort of things that we know kind of can induce some of these GI issues, but that's often a mast cell disorder. I didn't get the POTS yet, right? So she's got these three things. So when the patient comes into me, they leave and they get all these diagnoses. Like, I just thought I had dizziness. But the girl has POTS, okay, and we're going to talk about that a little bit more. The POTS then triggers the vasovagal syncope. And so let's talk about the mechanism for the POTS and the vasovagal syncope. So as I said, she's got stretchy connective tissue and importantly, stretchy veins. So when the upright and the blood falls, the pressure from gravity stretches the veins and the patients get loads of blood pooling. I'll show you some examples, but these patients will come in and tell you I've got blood pooling. I never knew what blood pooling was until the patient started telling me. We don't learn that anywhere. So she has the EDS, small fiber neuropathy, which was the last piece of the puzzle. Once she lost the connection from the brain to the blood vessels, which we'll talk about, then she no longer had venoconstriction. The veins weren't constricting when she stood up. So likely acquired from an autoimmune neuropathy related to COVID. By the way, the COVID vaccine is also a big instigator of neuropathy and POTS in patients who are susceptible. So that's just something to think about. So all of this together led to venous pooling, okay? Venous pooling led to not enough blood getting to the brain. We'll talk about the physiology more in a moment, but I just want to explain that the POTS then triggers the vasovagal syncope via a basal gyrus reflex. For anyone in here in cardiology, we came across this when I was a fellow, but it's an important reflex to know about because the basal gyrus reflex, it's just basal was in the 1800s and gyrus was in the early 1900s. The guy who discovered it actually I thought was cool. He just named it after both of them and he didn't even put his name on it. But this reflex is very important because when we see it in patients with infraposterior myocardial infarction as well. When there is nerve fibers in a zone at the back, at the posterior inferior wall of the left ventricle, when those get stimulated, there's a direct connection. It's an afferent signal backwards up the vagus nerve to the brain, the medulla, that basically does two things. It fires the vagus nerve and also causes sympathetic withdrawal. When you fire the vagus nerve, the heart rate slows. Usually you trigger nausea, queasiness, and with the sympathetic withdrawal, the blood pressure drops. And so the patients have blood pressure dropping at the same time their heart rate is slowing, and then they get, ultimately, there's an output of epinephrine, so they get cold sweats because the patient's sweating through cold skin. They get heart racing, pounding, palpitations, and so that's a basal gyrus reflex, but it's triggered by the POTS. Because if you don't have POTS, I mean, it's not just POTS that triggers it, but if your heart's not racing and you're not getting enough blood to the heart, then you're not going to trigger this. The basal gyrus reflex can be triggered by so many different things. It can be triggered by pain. It can be triggered by anxiety. Anxiety can trigger it, panic attacks, and others, including, like I said, the infraposterior MI can trigger a basal gyrus reflex, and that's why we see patients hypotensive and bradycardic on the table when they get a posterior MI. So this diagram is a nice diagram of POTS and the associated disorders and how it connects. Some of them are more important than others. So as I said, the connective tissue disorder with the hypermobile EDS, the small fiber neuropathy. There's some antibody things that can attack the receptors, especially the adrenergic receptors, and can cause POTS. It's like 1 in a million, but it's there, it's rare, but usually it's not POTS is not usually a solo thing that just happens. If you got an antibody reaction to your receptors, you can have POTS and nothing else, but rarely is POTS a lone entity. Excessive central sympathetic activation, those are the patients with anxiety and panic attacks, etc. That's not POTS. Inflammation, the mast cell stuff we talked about. Cardiovascular deconditioning. If you saw when these astronauts who were in space for 9 months, when you saw them get off the space capsule, they had to take them out and put them immediately onto a stretcher. Those people cannot stand up, okay? So they have POTS physiology because they lost a couple things. They get muscle atrophy, so the legs can't pump the blood. They actually affect their baroreceptors, and they get all kinds of changes that occur in space. But once they rehab, their POTS goes away. So really it's not POTS, but it's the same physiology, but it's just a great example. And they, like you can see, those people, they like to barely keep their head up. They had to talk to them on the interviews with them lying on the gurney. And then absolute hypovolemia from other renin-angiotensin things can trigger POTS, but that's not common. So let's talk quickly about the normal physiology of standing, because this is really the key. If you understand what happens when we stand, then POTS becomes a no-brainer. It's really easy. So we stand up. Our blood falls from our chest into our abdomen, pelvis, and legs. About 500 to 1,000 cc's of blood shift. When that happens, there's less blood getting to the carotid arteries and the aorta. So the baroreceptors, which are just nerve sensors at the top of the aorta and on the carotids, I think this is really, interesting, because we're very simple. Animals are very simple creatures. It's not like there's some computers, these baroreceptors, they seem so vague. It's a stretch receptor. If the carotid artery and the aorta are full of blood, the thing's turned off. If they're not full of blood, the reflex is turned on. So if you don't have enough blood getting up to the brain, then you turn on the baroreceptors. You have sympathetic activation, right? Because you want to have your blood vessels, your veins constrict to push more blood. Heart rate increases to get more blood flow, and you have parasympathetic withdrawal, so you're not fighting that. So you get the venoconstriction. The blood gets back up to the baroreceptors, they reload, and the adrenaline shuts off. But not in the POTS patients. So everything gets reset, okay? In the POTS patients, it starts out the same blood shifts, etc., but they have decreased or absent venoconstriction. They're not getting the signal from the brain to the veins, so they're not constricting, or the veins are so stretchy that even if they're constricting, you're not getting effective blood flow movement, or you get mast cells with vasodilators released that are causing more vasodilatation. The biggest area where we have this venous pooling is actually in the splanchnic bed. Abdomen and pelvis has thousands of feet of veins, okay? So the blood just hangs there. And actually on the cardiology side, they use this in patients with CHF basically as a reservoir. When you give a patient nitrates, okay, nitrates cause vasodilatation, particularly in the splanchnic bed. So what happens is you pool blood in the belly so you don't have as much coming back from the heart. So you use this just as the opposite. I have a colleague out in Salt Lake City who actually does a whole lecture and talks about how POTS is really a form of heart failure. It's really a preload failure. You're not having blood coming back, so it's not heart failure. But he does this whole really nice, eloquent lecture you can find on YouTube. His name's Craig Colby. And does this whole lecture on how POTS is really a form of heart failure. I wouldn't go that far, but it's the same physiology in that sense, right? So decrease of that absent vasoconstriction, no baroreceptor reloading, so the adrenaline is always going until they either lay flat or if they're super, super hydrated. Let me just show you what blood pooling is. It doesn't show up this great on here. Just look at this one's a little lighter, this is a little darker. Patients who have blood pooling, in the summer especially, when patients come into the office in shorts, skirts, etc., you look at their legs, you can tell when you walk in the room they get something going on because their legs are reddish, purplish, some get even blue. That's the venous pooling, okay? So the blood is really hanging in their lower abdomen, pelvis, and legs, and not as much getting up to the brain. And this is supposedly normal, but I will tell you a trick that I do is I just look at the patient, look at their arm and look at their leg at the same time. They should be about the same color. If they're not, the patient has venous pooling, so it's just something to think about. Now, this is a diagram that I drew some time ago, and I'm really trying to make it better, but it's hard to draw on PowerPoint. I don't know, maybe I'm just not good at that stuff. But this is an exaggeration, but if the patient is not fully hydrated, here the patient's fully hydrated. The blood is flowing, right? So the blood's gonna flow up to the brain. Guess what? We do not need our nervous system. If we're fully hydrated, the nervous system never gets activated in terms of blood flow. We don't need it. It's fine. Over here, if you're not fully hydrated, and essentially if the blood level, if we are like the tube that we are with a nervous system, if our blood level falls below the level of the heart, then now we have to venoconstrict in order to get the blood back to the heart so the heart can get it to the brain. So this is what's going to happen. If it's not working, the POTS patient is going to have an issue with that. But if they got an IV put in and gave them a bag of fluid, get 1 liter of saline. And their heart rate goes from high to normal, and they feel great, and they think you changed the world. You can't do that all the time, though, so that's a problem. Now, I just want to show what a tilt table looks like. Tilt table is a table that tilts. When I first heard a tilt table, I thought you're like on your back upside down, or they're swinging you around like a rotisserie. It is a simple concept, but I just want to explain what the concept is. Why a tilt table is better than checking the patient just standing. When we stand, we squeeze the muscles in our legs, etc., and they call the legs the second heart because there's a lot of venous return that occurs by standing just from contracting the muscles, right? And so if the patient gets atrophy, all the people out here who've had patients in the hospital, if you put a patient in a hospital bed for 3 days, and then you try to stand them up, they get POTS, or they seem like they get POTS. Their heart rate goes up, they may even have orthostatic hypotension, but get their muscles strong again. And that's why I became a big believer, and I have a lot of respect for our physical therapists, because those patients laying in bed, if they're not getting that physical therapy while they're laying there, they're all gonna have problems. Okay, so that's what a tilt table looks like, and basically, that's the concept there. Usually, we put the patients to an angle of, it's kind of debated, but anywhere from 60 to 80 degrees. If you put them at 90 degrees, you might as well just stand them up, because now they're standing on the on this foot pad and they can squeeze their muscles. But if you put them at an angle, they really can't do that. So you're really isolating just the autonomic nervous system to see how it's working. So this is just a quick graph of what happens in POTS. The blue are the patients with POTS, the red and black are control patients, male and female. But basically with POTS, table goes up, heart rate goes up. More importantly, as I was saying, the table goes up, the stroke volume, the venous return goes down, and so that is the key physiologic issue that causes the POTS. The stroke volume goes down a little bit in normal controls, but it goes down, it's over-exaggerated in patients with POTS. What it looks like on a tilt table test is the heart rate is here, the table goes up, heart rate goes up, stays up, heart rate goes up, it abruptly comes down. I call this the square root sign, because basically if you see a patient with POTS where their heart rate goes up, stays up, and then you end it, it comes down, that's POTS, okay? Very few other things do that. And then the exaggeration. Here is a control, it kind of gradually goes up, still comes down when they go up, but it's kind of much more gradual, and the heart rate's not going up very much. The more important thing is, even in POTS, this is the blood pressure, systolic and diastolic, blood pressure doesn't change. So treatment for this young lady, we're not gonna go into treatment today. I could do a whole 2-hour lecture on that one, but I'll talk about the basics. Oral fluids, going back to the first lecture, which by the way was excellent, I really enjoyed that. The water, and I'm gonna contradict what you said. So these patients need salt. So it's just the opposite, and I'm the only cardiologist, I feel like I'm one of the only cardiologists who has to tell the patient to have more salt. The guidelines are 8 to 10 grams a day, and some guidelines say 10 to 20 grams a day of salt. Salt does a bunch of things, right? Salt, number one, has osmotic property, keeps the fluid in the vessels. That's part of it. Salt is a vasoconstrictor. You get salt, their veins constrict, and that helps the blood to push. And number three, and this is a really cool one and important to me because I've been doing some really research on this just because I really wanted to study the concept of what else is happening, is when you have salt, you increase the solubility in the blood and you release vasopressin. We're going to talk about that more in a minute. But basically, oral fluids, salt, 3 liters at least of water, salt, compression. If these patients wear compression stockings, and not ones that go to their ankle, you have to squeeze as many veins as you squeeze. That's where there's no room for the blood to flow. So the higher, the better. Spanx, Italo Biaggioni, who's out of Vanderbilt, I give him credit for that one. He told me, Spanx, Howard. He's got this nice accent. But it works. Spanx, basically, if patients stand up, the blood can't fall. They feel better. Medications, like I say, to maintain hydration, and there's a whole bunch. Like I said, we'll talk about that at a different time. Treat the mast cell disorder. You treat the mast cell disorder, the POTS gets better, the GI stuff gets better, their rashes, flushing, hives get better, lots of things get better. And then consider IV hydration in the really difficult patients, because that's a great acute response thing. If you give them IV hydration and they feel better immediately. So this is just a poster I presented in November at the American Autonomic Society meeting. But basically, patients come to me all the time and they say, but doctor, I drink so much water. I drink all day long. But what they don't tell you is they also urinate all day long. And so I started thinking, what's happening? So they're taking the water in, and then they're just urinating it right out. So I thought, I wonder if their vasopressin level, if there's a problem with it. So I started measuring serum vasopressin levels. And in this study, 10 were vasopressin and 2 were copeptin, which we'll talk about for a minute. That's a marker for vasopressin. They were all, the lowest that vasopressin measures is less than 0.8. Each one of them was less than 0.8, which you usually see in diabetes insipidus. And copeptin is a glycoprotein molecule also released from the pituitary at the same time as vasopressin, and so you can use that as a marker. It's an easier assay. It turned out that the lab, when we called them, was throwing out the other 50 samples I sent them, they were throwing out because it says too difficult of an assay. We just don't like doing it. And so after that, I started doing the copeptins, and now I just order copeptin levels. You don't have to order copeptin, but I'm trying to use it as a marker for POTS, and I presented this, and it got a lot of play at the Autonomic Society meeting. People were really interested. One of the reasons I did it, and as I said, I can't talk about the long-term, I can't talk about treatment a lot. One of my drugs that I use for patients with POTS is desmopressin. Desmopressin is oral vasopressin. It is a drug that is usually prescribed for bedwetting. Really, the only indication is either bedwetting or patients who have pituitary issues. There's no other indication for it. However, I use it in POTS in various ways and basically replace their desmopressin, and it really helps their POTS. So that's that one. This paper I published in March 2022. I made it public access so everyone can look it up, et cetera. It's a really comprehensive paper on oral intravenous hydration principles for POTS, et cetera. This has everything in it in terms of all the medications that I use. I actually developed the first ever guidelines for the use of a port in the really sick patients in POTS. Ports are not usually recommended except for the really bad ones who can't do anything else. Dr. Cheshire, who's a wonderful neurologist down at Mayo, asked me to write the paper, and I love this stuff, but I'm not a great writer. I put all the information together, I held this whole packet, but I couldn't get across the finish line, and he was the editor. He said, "Hey, do you want me to help you?" And I said, "Great." I sent it to him on Friday, and Monday morning, this beautiful paper comes back. He's a magician at putting it together, and it came out really nice. Very proud of this one, but like I say, it's really a good resource for a lot of this stuff. So in conclusion, the patient developed POTS and vasovagal syncope following COVID-19. She had the underlying EDS and mast cell disorder, and with COVID developed a small fiber neuropathy, which triggered the whole thing because now she lost her venous return. Again, not dysautonomia, but actually autonomia, the autonomic nervous system responding appropriately. POTS is generally a disorder of venous pooling and subsequent decreased cardiac preload. The history and physical is absolutely hands down the most important test. The other stuff is just going to verify. And POTS can be difficult, becomes much easier to understand if you understand the pathophysiology of the disorder. Thank you very much.